So in 2023, we conducted a study to examine how stigma impacts Australian alcohol and other drugs and harm reduction workers and services. And this included whether having living or lived experience of substance use moderated these stigma impacts, or if it otherwise affected workplace wellbeing. We promoted the online survey via industry email lists and newsletters, and 228 people completed it. 64% indicated they had living or lived experience, and 84% provided written reflections about how drug use-related stigma has impacted them or their work. When we analysed the quantitative data, we found that workers who reported experiencing more of this stigma by association had poorer workplace wellbeing, greater levels of burnout, and stronger intentions to leave the sector. People with living or lived experience reported higher levels of job satisfaction and lower intentions to quit, but their experiences of stigma by association for their work role were similar to the broader sample. Using a modified version of the Health Stigma and Discrimination Framework, we then analysed the written responses to generate deeper understandings of how stigma is perceived and experienced. We focused on examining the manifestations of stigma, including ways that staff could be supported to work within a stigmatised context, and by doing so, how they can enable better outcomes for service participants. Respondents characterised stigma as a pervasive social devaluation that was imbued within healthcare interactions, and they reported experiencing secondary impacts from the stigma directed at their service participants. Stigma became apparent in settings where health workers showed reluctance to provide care to people who use substances, or when the care that they provided was impersonal or inadequate. This included witnessing people become ill or health workers fail to uphold their duty of care, which then increased work demands for AOD workers. For instance, a peer worker stated, "I have to accompany my clients to services within the hospital and community so that they don't get berated." Stigma made it harder to do the work. Workers described navigating contact with other services carefully to minimise possible negative interactions, and they felt frustrated and at times powerless to prevent the poor treatment that they observed. Stigma was given as a primary explanation for why AOD and harm reduction services tended to be separated from other health services, why their work was not adequately funded or supported, and why it was difficult to make service improvements. For example, people who inject are seen as problematic and undesirable, visually disturbing, and a safety risk. We can't do the work that we need or want to do to improve services in a timely way because there's always concerns about risk. On the other hand, respondents described how their passion for social justice was operationalised in advocating to address the social determinants of health for people who use drugs, and that observing stigma was at times a motivating factor for continuing in this work. The effectiveness of the alcohol and other drug sector in attracting workers who wish to express or further develop empathic behaviours and socially progressive ideals could be considered an indirect and beneficial impact of stigma. The stigma towards AOD service participants had negative personal impacts on workers, including assumptions of being low-skilled, incompetent, morally compromised, and perceptions of their services as ineffective or even damaging if they were not focused on abstinence. Some respondents were selective in what they told others about their work, and many described how defending the importance of their work and educating others about the harmful effects of stigma was common in their social interactions. One worker described the impacts of this stigma by association in the following way. When the clients I work with are stigmatised, the work they do to better themselves is stigmatised. That includes the work that I do with them. I am not stigmatised as a person or worker, but my work effort is stigmatised. Peer workers gave compelling accounts of how their experiences of stigma enabled stronger connections with service participants, but they also described instances of discrimination such as being paid less and of feeling undervalued or judged, particularly when working alongside colleagues who had internalised or expressed negative attitudes towards people who use drugs. disclosing living or lived experiences, or moving into peer roles could involve losing power and being vulnerable to negative attitudes, particularly where there was poor workplace culture or staff cohesion. So to summarise, understanding and combating stigma is vital but under-acknowledged work performed within harm reduction and alcohol and other drugs services. Supportive organisational cultures help workers gain meaning and satisfaction from their work, buffering against stigma and burnout. Understanding and reducing the impacts of stigma on workers will assist in attracting and retaining staff, and an initial suggestion towards this could be to routinely identify and examine the expressions, conditions, and effects of stigma within individual and team reflective practices, as well as within service quality improvement processes. Thanks to the study participants and the other researchers involved, and these are the 2 papers that we've produced from this data. Thanks.